The challenge of urethral strictures is huge, both in terms of the burden in the society and also the kind of presentations that stricture patients do present. Male urethral stricture, that means blockage in the urinary passage of men, which could be happening anytime between this location all the way till here, and then this location in cases of road traffic accident. The entire thing, which is called as the male urethra, could actually have a narrowing or the blockage in the passage without your and my knowledge. Now, stricture urethra could result from inflammation or infection, could result from catheterization, traumatic instrumentations, injuries, accidents, road traffic injuries, major traumas, many other factors. So urethral blockage or urethral narrowing, which could lead to a poor flow of urine, is not a diagnosis which is uncommon. Quite a common diagnosis, many a times is missed out when men present with recurrent urinary tract infection. A young man presenting with recurrent urinary tract infection is asked a question, do you have a good flow of urine? And he says, no, my flow is very poor. It's there since long time, since I remember I had a bicycle rod injury in my childhood school days, or I had a cricket ball injury, or I had a road traffic accident or a trauma, or some kind of a catheterization post-surgery thereafter, there was a catheter injury. So there are multiple reasons a patient may miss out his stricture urethra and may present to you with only infection, fever, chills, and on deep questioning, we pick up that he has got a stricture urethra. Compared to somebody who sadly had a road traffic accident of a massive kind, where there was a fracture of the pelvic bones and the prostate and the urethra region, which could get crushed or which could get damaged. And on the very day of the injury, when there is a multidisciplinary team taking over on the various more emergent injury aspects to probably safeguard life and to cure him back, the urinary passage doesn't allow the catheter to go in. And that's a time of posterior urethral distraction defect or an obstruction which is almost complete because of the fracture, pelvis, and injury, requires a suprapubic cystostomy or putting a catheter through the abdomen into the tummy or the urinary bladder directly. So patients after road traffic accident having blockage of urine who have got a stricture urethra that is impassable, through which urine cannot pass and tubes and catheters cannot go, have a posterior urethral distraction defect, which is managed temporarily for first few months and thereafter by a suprapubic cystostomy or a catheter which is going through the bladder directly from the lower part of the tummy or the abdomen. Now, these patients therefore are cured later on by doing a urethroplasty where you bring about a repair. A repair or a urethroplasty of a very narrow pipe called the urethra is a requirement for all patients who have got a urinary blockage. The two kinds of urethroplasty that the world of reconstructive urology does, which at the Kokilaben Hospital we continue doing for men very young to middle-aged to elderly, is about doing either a substitution urethroplasty, where we substitute a segment of urethra that has got diseased, which I said basically for inflammation and on aspects of changes which have happened on a longer segment of urethra, more on the anterior or more on the distal parts of the urethra, which I said, that part. So that would possibly be by an augmentation or by increasing the caliber of the urethra, more commonly by a buccal mucosal graft urethroplasty, which is a great substitute that it gives away a donor part of the tissue from the oral cavity, which can be incorporated to bring about the improved circumference of the urethra through which you can pass urine well again. So urethroplasty of that kind, which requires a catheter for 2 weeks, allows a healing and sealing of that entire circumference which has been substituted, that was missing because the urethra was much narrow. So a narrow urethra is turned into a broader urethra of the kind that you had, broader than that, for it should tighten up in due course of time, which is a healing process and a journey that has to be taken forward very, very closely. So post various kinds of inflammation, which could even be sexually transmitted, which could be post-inflammation, which could be post-trauma of the catheter and of the other kinds of injuries, we normally do a substitution urethroplasty for a longer segment of disease. Compared to a shorter segment of disease, we would look at anastomotic urethroplasty, where we would look at bridging the gap and removing that disease segment and repairing it. So that kind of a repair where you do an anastomotic repair is taken up through the perineum area, from where we will not know whether we operated you few weeks or few months later. So urethroplasty of that kind, where we do an anastomotic repair, is for short segment fibrous strictures which are really impassable, through which urine comes out not freely, and just been there for quite some time and probably has been missed out. Or many patients undergo something called as optical internal urethrotomy for a short segment stricture, or a stricture which has been firm and fibrous and have chosen a minimally invasive technique which sadly fades. So looking at good success rates in urethroplasty is about looking at the segment, looking at identifying the technique that you need to do. And that's the crux of reconstructive urology that we continue to practice. Urethroplasty of the posterior urethral kind, where there has been a road traffic accident, which I need to dwell into. And many people are crippled with that in terms of having recovered from all, but not having recovered from this. A classical example is there in this film, where you would see that a young man who had a road traffic accident years ago and probably could not have passed any urine on the day of the injury and thereafter, recovered from all the aspects of the injury, but did not recover from this, actually was from the day of his injury on a suprapubic catheter, a urinary catheter, which actually is directly going into the urinary bladder. So that's the area of the urinary bladder. That's the area of the prostate. And that's the area of the urethra or the male urinary pipe. The road traffic accident, which brought about a fracture of the pelvis and the injury in the region of the pelvis here. So the bones got injured, fractured, there was a hematoma, bleeding, callus. All this happened, choked the urinary passage in that area, as a result of which urine would not come on the very time of the accident and beyond. Attempts at catheterization and pushing a tube cannot go inside, as a result of which the emergency team or the emergency urological team at that point in time, in posterior urethral distraction defect and in all road traffic accidents and all war injuries, all kinds of massive injuries where there's a injury at the level of pelvic bones and urine cannot come from below, but there's a blood at the urinary meatus, puts a suprapubic cystostomy or a tube through the urinary bladder directly. So it's coming through the tummy and it's draining the urine through the tummy outside. Whereas the low urinary passage, which is a passage that is not intact today, but has to be made intact towards future, is left alone without any trauma, injury, attempts, and just messing it up more. While that happens, injury heals around, the patient recovers completely and undergoes a monthly change of suprapubic catheter. He comes in here and we do a reconstructive work where we repair that segment which has undergone a distraction, which has undergone an injury, which has undergone a perforation, and the area has obviously got fibrosed and sealed. So that kind of an anastomotic urethroplasty, which is undertaken through the perineum, where we sometimes have to dismantle a part of the bone chips, remove a lot of fracture, hematoma, callus, which is all hard tissue stuck there and therefore not letting the passage actually get through on day one itself, is then brought about by a repair where the area is bridged. This bridging is done about by mobilizations, by interpositions, by mobilization of the urethra, taking into consideration his male function, taking into consideration his future urethral function, that he should pass urine like a child again through the urethroplasty segment, which is being repaired. So that repair entails a degree of expertise, entails a degree of renewed vigor in terms of right approach to the right individual, because many patients deserve a different kind of technique. Some may require a bone chiseling, some may require only an anastomosis, some may require a little progressive approach where we have to do an up and down attempt. Some may actually require a transpubic surgery where we may have to remove a part of the bone and bring both the segments together. So these are complex surgeries. Urethroplasties of that kind are different, and that's something where we undertake for all patients who are living with injuries of that kind. Many of these road traffic accident injuries also have rectal injury. The injury in the rectum, which could lead to a leakage of urine through the rectum. So there could be a leak of urine through the motion passage. And that leak is called a rectourethral fistula, which could be a kind of a composite organ injury which must have happened. Many of these patients actually have got a colostomy or a bowel segment brought out through which motion comes out. So imagine a patient with a massive road traffic accident, a war injury, a kind of an injury where he got crushed completely, has a urinary pipe through the urinary passage, has a colostomy or a motion passage coming out. So both the lower passages have been defunct. They have been made non-functional, they have been diverted. That diversion has later on to be undiverted after repairs of each of them. In that situation, we will do a rectourethral fistula repair. That means we repair the fistula or the communication between rectum and urethra, separate them completely, bring about a nomental flap or a gracilis muscle flap, and keep them separately. And therefore, the urethra is repaired as a urethroplasty. So these are more complex. They may take few hours. They may take sometimes 1 or 2 sittings. By the end of it, people walk scot-free. They are repaired. They probably lead a healthier and a better life. They don't have to live on tubes and bags, which is a part of the folklore of many of these people who are crippled and possibly operated once or twice. And we get to see a lot of redo patients underwent surgery in various parts of the country and the world, whom we have repaired once, have failed, and then probably are living on tubes and probably have been told it cannot be done. And then they come over. So at the Kokilaben Hospital, the reconstructive urology unit, where we do various kinds of reconstruction on the male genitals, on the female organs, on the various kind of leakages of urine and obstruction to various segments of the urinary passage. Urethroplasty is a very, very important tool that we need to look into. For the anterior urethra, which I talked about, or the penile urethra, we normally do a substitution urethroplasty. If any segment or a longer segment is diseased, sometimes the entire segment is diseased in a disease called BXO. We replace the entire segment by a buccal mucosal graft urethroplasty, where we take the inner part of the cheek with a very thin lining, repair and augment it. So you're augmenting the caliber of the urethra by actually replacing that segment, which was quite fibrous. And that's done by umpteen techniques that we continue to practice. Again, as I said, the right approach to the right individual will only take them forward in the journey of repair and probably healing around. So urethroplasty is a cup of tea for a reconstructive urologist, is a kind of a complex surgery where he immerses deep into the perineum, deep into the pelvis, looks into that, and that is a niche subject which over the last 2.5 decades in urology, me and my colleagues in the country have taken up on those aspects of care, which is such a big burden right now. That burden has to be taken care of. I think the awareness on this is missing. Unfortunately, we all look at minimally invasive surgeries. We all look forward to an endoscopic job, which may not be beneficial in all. Frankly speaking, an optical internal urethrotomy, or what we call as an endoscopic job, is only for a short segment mucosal stricture, a stricture which is only involving the inner lining and the mucosa, where an incision could help us out and we open up that segment and probably take it forward in terms of calibrating and keeping the journey of healing where the mucosa bridges without tightening up. So that aspect of care is for a very specific group of strictures. Unfortunately, over the demands that has happened over years and over the kind of requirements that people have, everybody wishes to have an endoscopic job. All endoscopic jobs may not succeed. Therefore, urethral stricture has to be stratified. Each urethral stricture could be for a different amount of time. Each urethral stricture could be having a different morbidity in the type of the fibrosis it has evoked as a result of the inciting factor, which could be a trauma, injury, a catheter, an inflammation, name it. And there are n number of reasons you develop a stricture urethra or a blockage in the urinary pipe, which could be a complete block, which could be narrowing of the pipe. Narrowing of the pipe, you're not passing urine very well, living with the entity, and possibly one day getting infection, which is the end result of a disease, and that's what is unfortunately treated around. So I think stricture urethra needs a lot of awareness. That awareness is missing in public domain. And as we come closer to you, to the society, in terms of explaining that this urinary pipe, which is an intact pipe in you and me, could be completely blocked in somebody who lives with a urinary pipe through the stomach and his urinary passage is completely defunct. So that kind of a repair can be done completely. They could pass urine again and well. And therefore, any kind of an endoscopic job in these kinds of fibrous strictures, blocked conditions is not a good idea. Urethral stricture is a disease which can sometimes progress, and therefore assessment of these diseases is equally important. A good assessment, a good evaluation, and a thorough treatment, spending time into this and probably doing it for once and all, probably following up very closely with your surgeon after having done a surgery is also equally important, because healing of this narrow tube, the tube itself is very narrow. You can imagine how narrow your urinary pipe is when you look at the organ and the tip of your organ. That narrow pipe has already got tightened up. And then we take multiple stitches and repair and heal it, obviously through a good spatulation where the pipe has been broadened up. It should not tighten up anymore. It's important for urethral stricture awareness to go to the society, to the needy, and to all those ambassadors who listen to this subject, because stricture urethra is a deadly difficult disease where people live with it. They don't know whom to go to. Many times they get a repair and the repair fails and they come back again. So retrourethral fistula, stricture urethra in both men and women, incontinence of urine, blockages are all domains of reconstructive urology, which feels very good to be able to do it. Obviously, these are very challenging kind of indications, and each patient is different from the other one. Thank you so much.